Mehdi Ashik Chowdhury. I welcome you all to our today's CME presentation. There is nothing new about. I'm very honored to have such a learned audience, such experienced doctors in front of me. Some of you are contemporary to my teachers. So there's nothing new about pathology. I can share with you that you already don't know. Rather, we decided to go with a topic important in all of our lives. That is communication. A good communication can save a relationship. A good communication can stop wars. And in our case, save lives. So unlike the clinicians who consult the patients, we as histopathologists have to consult the consultants. So today's presentation will focus on minimizing, subduing, reducing, or recovering all the communication gaps that we face. First thing first, we have to send this message loud and clear. Please ensure fixation by 10% formalin in all the biopsy specimen. We know this, we practice this, but we have to keep reminding ourselves. And when it is sent, ideally the specimen should be submerged in formalin and the jar should be big enough to take the specimen out without damaging it. Because even after saying it so many times, we find advices like this, written by doctors: send the specimen in salt water. In Bangla, it is written, lobon panite pathan. And this is the result, if we remember our third year pathology a little bit. No nucleus. This is what a coagulative necrosis looks like. No nucleus, only cytoplasm, no way to make any diagnosis, no way to make any prognostic value except for repeat biopsy. Once I had a case a few months back, bladder tumor, and under microscope I found a prostatic adenocarcinoma. So my diagnosis has to be metastatic adenocarcinoma of prostate in bladder. That's what it should be. And it is from STIMC, Shodor Hospital, no surgeon name written, nothing written there. So somehow I managed to contact the surgeon and I asked her, is it a bladder tumor? Because I am seeing a prostate cancer. The surgeon told me, no, it's a prostate. It's a prostatic chips. Maybe some intern wrote it by mistake, gave it tumor, bladder. You correct it. So this minute mistake can lead to major medical legal issues. Also, another case scenario I had in my practice, a brain tumor. The diagnosis was glioblastoma multiforme. Unfortunately, a very grave grade 4 brain tumor. The patient gets only like 6 months to 1 year to live. The neurosurgeon called me up and asked, I sent the same specimen to a very reputed lab in Dhaka and they said reactive gliosis. How did you diagnose cancer? So I asked, sir, how did you send the same specimen to 2 places? You sent it to me. He said, no, I divided it in 2 halves, gave one to you, one to Dhaka. So I said, sir, you can take my slides and blocks and please recheck it. Because I'm quite confident it is a GBM. So they sent the slides and blocks to India and the report came glioblastoma multiforme. So did the Dhaka lab make mistake here? What do you think? Where is the gap? When we divide the specimen in 2 halves, under naked eye, we cannot be sure which half contains the representative malignancy. So the Dhaka lab got the reactive gliosis part. He is also correct. But obviously, you want to recheck it. As a surgeon, as a patient, it is your right and privilege to take second opinions. So you just simply take the slide and block. You give the whole specimen to any lab you like, then you take the slide and block and you recheck it as many times you want, as many places as you want. But dividing it will cause mass confusion. Pass for histopathology. Can we do pass for histopathology? We cannot. It's a liquid substance. So I have to call the patient, cancel the receipt, and patient is dissatisfied. Patient felt harassed. Specimen for biopsy and histopathology. Which specimen, from where, no information. No information at all. And these informations are necessary. Why necessary? I will show you in this slide. This patient, Anwara, 60 years old, tissue from stomach. That's the requisition I got, tissue from stomach in my practice. Under microscope, I found a squamous cell carcinoma. Now, squamous cell carcinoma is highly unlikely to be found in stomach. And if I sign out this report, there is a good possibility a surgeon will plan for a gastrectomy on the basis of this report. So I called the patient and asked for the endoscopy. The patient initially didn't agree. Why you want this report? Do you want to copy? Do you want to copy your diagnosis? You make your own diagnosis. He was like that. I convinced him somehow, and the report he provided me, biopsy is taken from esophagus. It's an esophagus. Squamous cell carcinoma is common in esophagus. So if I have signed it out, I would have been in grave medical legal danger, and the patient party would have been harassed for sure. So please, we need these informations. And I am very fortunate, very lucky in TMMC, in this institutional, that's why institutional practice is important. Our surgery department, our Professor Ranjit sir, and all the clinicians, they are very much communicative with us. They provide us with all this information, and that's how it should be. Another controversy arises in cytopathology, because in cytopathology, sometimes final diagnosis cannot be made. In some cases, I will show you why. This is a stromal fragment supposed to be found in fibroadenoma, but this is actually a breast carcinoma. It does not always follow the theory. Lymphoma must be confirmed by histopathology and immunohistochemistry. Even if the diagnosis is made in FNAC, it should be reconfirmed. This is from a very reputed lab in Dhaka. Everyone knows the lab by name. Is the go-to center for histopathology in Bangladesh. This is one of the diagnoses, atypical lymphoid hyperplasia. I'm sure none of you are very accustomed with this term. Is it lymphoma? Is it inflammatory? What do you think? Anyone would like to contribute? Do you think it's a malignant condition or not? It's actually neither of those. It's a non-conclusive diagnosis. So this can happen even in histopathology sample. In that case, we have to go for immunohistochemistry. Another confusion, granuloma. We all know what granuloma is. And why do we find granuloma commonly? Why do we find granuloma commonly? Thank you. Tuberculosis, exactly. But there are many other causes. So when we write granulomatous inflammation, it can mean any of these, even malignancy. In squamous cell carcinoma, in Hodgkin lymphoma, we can find granuloma. So when we write granulomatous inflammation suggestive of TB, this is probably TB, but it needs clinical correlation and further evaluation, auxiliary testing. When we write consistent with TB, it is TB, because we have found AFB. When we write tubercular abscess, it is TB. Not all granulomatous inflammation are tubercular. They have their own entity, like granulomatous mastitis. Many times, I have seen patients after being diagnosed as granulomatous mastitis being given anti-tubercular drug for 6 to 7 months, only to end up worsening the disease. Because most of the times, granulomatous mastitis or granulomatous prostatitis, these are non-tubercular, even though the diagnosis is granulomatous. I don't know if you can comprehend the picture. This is a very good picture of granuloma that we find in tuberculosis. This is from my practice, but this is actually a small cell carcinoma. In other part of the slide, it's a small cell carcinoma. I wrote a paper on this. It is available in ResearchGate also. Invasive ductal carcinoma with ipsilateral lymph node harboring primary TB. It is supposed to be metastatic ductal carcinoma in lymph node, but dual pathology, rare but possible. In medical science, 2 and 2 sometimes equals to 5. So how to overcome these confusions? We must aid it with auxiliary testing. clinical correlation, further evaluation when necessary. So does that mean FNAC is not a good test? It can give rise to so many confusions and everything. What do you think? I will just share some of the cases I have done in TMMC and outside also of FNAC diagnosis. This is a FNAC diagnosis of rhabdomyosarcoma. Very diagnostic. This is a basal cell carcinoma, very diagnostic. This one I think you can diagnose even yourself. Can you please zoom in the circle slide? This is a lymph node. It's a FNAC. This is a lymph node, and in the circle there is a cell that has two nucleus. We call it mirror image or owl-eye appearance. Can anybody tell me what could be the diagnosis here? I think many of you have made the diagnosis. It's a lymph node with a giant cell that has mirror image or owl-eye appearance, binucleated. Exactly, thank you sir, Jafar sir. Can you get a clap for Jafar sir? Sir amader bhat mere dise. He just made the histopathological. It is a Hodgkin lymphoma, so it can be diagnosed in FNAC. These are metachromatic fibrillary stroma of pleomorphic adenoma. Again, excellent diagnostic criteria in FNAC. These pictures, when I was clicking by my mobile phone, my AI camera said flowers. He diagnosed these two as flowers. So these flowers or papilla, what we call, in my right, this papilla is from thyroid, and this is a papillary thyroid carcinoma. And this papilla is from breast, and this is a fibroadenoma. So same structure from different area can mean totally different diagnosis. And the message here is that's why FNAC should be done by the histopathologist who will give the final diagnosis in the slide to make a better clinico-pathological correlation. This is a 25-year-old female with ductal carcinoma diagnosed in cytopathology. So FNAC is actually a good test. And these days, cancers are not absolutely uncurable anymore. Many cancers such as papillary thyroid carcinoma, basal cell carcinoma, Hodgkin lymphoma, ductal carcinoma before being metastasis to lymph node, these are very much curable if diagnosed early. And FNAC plays an excellent role in this early diagnosis, or at least warrant the need of further evaluation. Is there anything wrong with this advice? FNAC from lung lesion? Abbas sir?
Yes.
Sir, do you think is there anything wrong with this advice?
It's a big term, lung lesion. But the lesion,
This could be more precise. Exactly. Thank you, sir. Exactly, sir. Exactly. That is the point. It should be CT guided. It should be CT guided. Many times patient comes with this. This costs like 1500 taka. And CT guided FNAC costs around 7,000 to more. Now patient party is not convinced to buy the receipt of 7,000 because it is written only FNAC. The patient doesn't believe me as much as he believes you, the clinician. We have to send him back. He writes it back. He comes back. The patient is dissatisfied, feeling hassled, annoyed. So it should be CT guided FNAC. And CT guided FNAC can yield excellent result. We have a published paper on this. We did 171 cases, both here and outside. We found 80% of them to be malignant, followed by tuberculosis, aspergillosis, and inflammatory lesion. So CT guided FNAC can yield excellent diagnosis in lung. 79% came out malignant. Actually, most time malignant lesions are referred for FNAC cases, most of the times. So FNAC is an excellent mainstay diagnosis. But is there a better option? There is. A better option is core biopsy. It is also minimally invasive. It only needs some local anesthesia and some post-procedure antibiotic, but minimally invasive, no suture needed. And it can give us histopathology specimen. So when malignancy is suspected, please advise core biopsy. When preoperative immunohistochemistry is required, such as breast carcinoma, we need ERPR HER2 status to give neoadjuvant therapy. Please advise core biopsy. So in a nutshell, we can advise core biopsy to breast lesion, lung lesions, liver lesions, CT guided core biopsy in case of internal organs, and Any lesion that exceeds the size of 2.5 centimeter is a good candidate for core biopsy. So these days, actually, only reason not to advise core biopsy is if the patient cannot afford it or the lesion is too small. However, it has pitfalls. Like some tumors range from benign to malignant, like cyst, fibroid, phylloids, desmoids. Some part of it may remain malignant, other parts benign. In this case, core biopsy fail. Everything has their pitfall. There is a conception that bone biopsy may not be possible, but actually, in a bony pathology, the bone becomes very fragile, and bone biopsy can yield excellent result. I'll just show you an example. She was a student from TMMC Nursing College, 19-year-old girl with a tumor in the knee. You can see the biopsy needle going in the lesion, and can you please enhance this image a little? Thank you. Stain is not very good, but if you can see, there are cells, there are giant cells with multiple nucleus, many nucleus in one cell, and these are giant cells. I think Abbas sir already made the diagnosis. This is a knee joint tumor with many giant cells. What do you think it is? Anybody please? This is a giant cell tumor of bone. Very diagnostic in core biopsy. Next please. We don't advise cervical smear enough. A cervical smear should be advised to every woman above the age of 21 years or after being sexually active 3 years after. This is a WHO guideline to healthy women, not unhealthy. And underage pap smear is not really necessary before 21, unless otherwise there is indication like discharge or anything. And this report should be done by a pathologist. There are other specialties like clinical pathology. This report was done by clinical pathologist and the report came normal. This was again sent to me, referred by my mother, who happens to be a doctor also. And I saw it's a high-grade lesion. And later it was sent to BSMMU, and in biopsy it came a high-grade lesion. So if the patient did not do the repeat pap smear, she would have gone on to develop cervical carcinoma. She would require major surgery followed by many cycles of therapy. And even then the chance of survival would be less. So that's why every specialty has their own field. Cyto and histopathology has to be done by a pathologist. This is my thesis research on cervical smear. We did a newer method, liquid-based cytology at BSMMU for the first time in Bangladesh, and since then it is available in BSMMU commercially, but it is available in ResearchGate if you want to look it up. Why am I sharing this? Interestingly, in our research, we found out that even though it is costlier and it has some advantage like reflex testing, the accuracy and specificity are almost as similar as conventional. So right now in our country, we don't need costlier methods. The conventional yields good enough result. We just need to implicate it. Synoptic reporting. In a malignancy, the reporting should be done in synoptic pattern provided by College of American Pathologists, CAP, adopted by WHO. So if you don't get a synoptic reporting in a malignancy, please demand for it to maintain the international standardization. Just take a water break. Another story, please bear with me. I got a TU and BT sample, bladder tumor. There was no muscle present in it, so I gave the stage T1 and no muscle present, I mentioned it. The patient went back to the urologist and the urologist collected the muscle again and sent it to me, but the tumor was not involved. So the stage remained T1. In bladder tumor, it is called T2 when it is involved in muscle. So the patient went to Asan Mission Cancer Hospital. There's a doctor received him, an MBBS doctor who was aiding the oncologist. He saw the two reports and he said, the histopathologist mistakenly given you the same report again. It's T1 in the first report, T1 in the second report. It should be T2. This time muscle is present. The patient came to me angry, charging, annoyed. Why are you doing this to me? You're making me run back and forth. You gave me the same report again. So I called the doctor and I asked him, and I explained to him, the muscle is free of tumor. It will remain T1. He said, oh, okay, send him back. So what happens is, in the meanwhile, the patient is being annoyed. And in his mind, maybe he is planning to go to India and saying to his relatives and surrounding, there is no treatment in Bangladesh, even though everything is being done. Another controversy we face, the endoscopist is seeing a malignancy. Even I will agree it's a malignancy seeing the endoscopic picture, a very ulcerating, fungating growth. I agree. In my slide, there is no malignancy. What to do here? What should the surgeon do? Everybody in mass confusion. What happens? Every malignancy has a superficial ulceration. In the endoscopy, it is seen. If the biopsy is only taken from the ulcer, I will not find any malignant cell there. That's why to exclude malignancy, it is a protocol. It is recommended to take at least 6 or 7 pieces. 90% of time, we get 2 or 3 pieces. So these are the uncertainty phrases sometimes we have to use, like suggestive of. This means you have to correlate with clinical condition, with history, with tumor marker, with further evaluation if necessary. Even in international standard, these terms are present. In Bethesda category of thyroid, there is a term atypia of undetermined significance, category 3. In cervical smear, there is a term atypical squamous cell of undetermined significance, ASCAS. So these are internationally adopted terms that sometimes has to be used. C description please. Many times clinicians are disappointed with a C description please diagnosis because what to do with it? But this can happen again from a very reputed lab in Dhaka. It's a very favorite lab for the ENT surgeons. They prefer it very much because they do give very good diagnosis. The diagnosis is C description please. Why? Because it cannot separate between a minor salivary neoplasm and squamous cell carcinoma. What to do in this case? You have to go for immunohistochemistry. This is again one of those descriptive terms. Cellular follicular lesion in thyroid can range from adenoma to carcinoma. There are some newer terminologies. Encapsulated follicular variant of papillary thyroid carcinoma. Whenever I give this diagnosis, many times the ENT surgeon calls and says whether it is benign or malignant. Then I have to explain it's an indolent malignancy. It is malignancy, but it will not spread. This is a category that is newly introduced by WHO. And many values have changed. Even I have taught in my class that in semen analysis, the motility has to be 60% in first hour. I have taught myself, but these days WHO is telling it has to be only 32% in first hour. The morphology, we used to tell 40 to 50%. Now WHO is saying only 4% morphology is suffice to call it normozoospermia. Even the count is decreased to 15 million. Previously it was 20 million. So you have to be accustomed with the changing values and terms also. We are all in a hurry. When we send a sample, we are all in a hurry to get the diagnosis. Obviously, it's a matter of life and death. So because of that, we the histopathologists have to be very careful. Say a Whipple's operation is sent. It takes long time to do the operation. It takes long time for us to do the grossing also. A large Whipple's sample, to take out the tumor and the margin, it takes like 45 minutes to 1 hour. After that, the processing from this large sample, a small slide is made. This process takes 3 to 4 days. Now in that slide, I did not find the malignancy. Maybe it is in deeper tissue. We have to do a recut. It will take another day. Maybe the invasive margin is very much ulcerated. I cannot be confirmed. There are special stain like PAS to apply to see the breach of basement membrane. We don't apply it routinely because it is costly. So when we apply it, when necessary, it will take another day. And maybe in the meantime, a Friday also happened. So in all the process, the report is sometimes delayed for very good reason. total count is 15,000 and lymphocyte is 70%. Do you think it is normal? Is it normal? Many are nodding no, it's not normal. But if these values are of a 1-year-old child, is it normal? It is normal. Abbas sir is saying it is normal. So our pediatrician head sir is saying it is normal. So we have to keep in mind, remind ourselves that under 5 years old, the total count will be raised. Not necessary to go for antibiotic or think of sepsis unless it crosses the international value. Today Google is available, everything. You can just go up and look for the values. But below 5 years, lymphocyte differential count will be more, total count will be more. The values we commonly remember is for adults or above 5 years. Many times platelet diagnosis can be wrong, so it must be rechecked manually. Because many times machine can give a false diagnosis due to giant platelets, teleotosis, cytoplasmic fragment, dust. Machine sometimes count dust particles as platelet. Sometimes the blood could be clotted before examination. So these all things should happen under manual observation. This happened, I was getting a CBC report of leukemia. So I gave it, there was no PBF, so I just gave it there a blast cell, I mentioned everything. But they were repeating it. They were sending me again like 3 times in a row, they were sending me the CBC. That time dengue was at rampant. So they were probably just focusing on the platelet, whether it is decreasing or increasing. They were not seeing the blast cell in the report. So I later called up, told them this is actually a case of leukemia. So thrombocytopenia can also mean other diseases. We have to exclude everything based on the whole report. And when confused, we must advise a PBF. This is an example of a good communication. I made a FNSC and the diagnosis was an epidermal inclusion cyst. Later it was biopsied and sent to some B2B lab to India. Some lab in India, I don't know. You can see the diagnosis. They said it's squamous cell carcinoma. So the surgeon called me. What happened? I went back to my lab, checked my slides, took the photos and sent to surgeon. This is an inclusion cyst or sebaceous cyst. No doubt. You please send the sample to some other lab, if not me. And he sent the sample to another lab and it came epidermal inclusion cyst. So because of the communication between me and the surgeon, many confusions could have been avoided. So we'll just end with some food for thoughts. What do you think about this question? Is India and Western world better than us in diagnostic pathology? I think all of you will agree, yes. But this is not an absolute answer. This is not an absolute answer. I tell you what, I had a diagnosis of ductal carcinoma of a doctor's relative. She was immediately sent to India through some marketing agent maybe. And I followed up. I kept asking what the diagnosis came there. They stayed there for 3 months and ran multiple of tests, lakhs of rupees spent. After 3 months, they agreed it's a ductal carcinoma. After 3 months. In the meanwhile, she developed axillary metastasis. The doctor later really regretted to me. So I'm not saying we are far ahead than them, but we are not far behind also. In my experience, I have seen poor patients in our country get good treatment. They don't question the doctor, they don't analyze the doctor, they take the treatment, they follow the instruction, they recover. Hundreds of thousands of patients around Bangladesh in government and private medical college. How are they getting treated? Not everyone can afford to go to India and Singapore. How are they staying healthy? How are they recovering? Because they are giving good compliance to us. What happens with the rich people or well-off people? They see one doctor, they recheck it with another doctor, they WhatsApp the prescription to a relative first-year-old medical student to verify if the professor is right, and eventually goes to India. All in the meanwhile delaying and complicating the disease. So we do make mistakes, but I think with better communication between us, between patients and doctors, media and society, we can really win back this fraction of trust that we have lost recently and stop this or reduce this outflow of patients to outside country, inshallah. Thank you. That is my presentation. Thank you.